to be here with you and sharing a few thoughts about prone positioning, but mainly what we've learned about COVID-19. So I've got no conflict of interest for this talk, and I just want to start with the idea about prone positioning. As you all know, the pathophysiological idea of prone positioning is based on this anatomical model of ARDS, which is the sponge model of the lung. Essentially, you've got increasing pleural pressure from the ventral to the dorsal. You've got gravity with superimposed weight, and then air gets squeezed out, and then essentially we've got a consolidation, and that could be reversed through prone positioning, regaining aeration in the dorsal position. But you are very well aware that during COVID-19, the situation, particularly at the beginning of the first wave, was very different. You can see a very different pattern of consolidation or collapse, but the main thing was a perfusion defect. You know, there were areas of hyperperfused area of the lung where there was some ground glass or some consolidation. And that led to this idea, which is very interesting. You can see this is a, let's call it typical ARDS, and this is COVID-19 ARDS. And you can see that in COVID-19 ARDS, there were more dilated vessels in the area of consolidated lung, which led to greater dead space and shunt fraction for the same anatomical consolidation, which also was related to mortality. So the greater the dilated vessel score, the greater the mortality. Also, there was another confounding factor which was demonstrated subsequently, that there was an opening of the intrapulmonary bronchopulmonary anastomosis, essentially creating an extracardiac and extrapulmonary shunt, which obviously is not affected by recruitment or sometimes by prone positioning. So that was the position that we were when we are not sure during COVID-19 whether the pattern that we saw in typical ARDS was replicatable in the COVID-19 ARDS. And this is just the idea, it's a modeling, but it's very interesting because when you compare patients with an anatomical shunt based on CT scan calculated about 17%, when the shunt fraction was calculated based on gas exchange, that was more similar to 50%. So there was a threefold increase in shunt fraction, which was due to a pulmonary vascular abnormality. So let's see what happens in a prone position during COVID-19. Let's start with the physiology. And this is a very common, you're very familiar with this, essentially in supine position, follow the feet. You can see there is a mismatch between ventilation and perfusion. And so there is a change in ventilation-perfusion matching, which goes high in the sternum, so more perfusion, more ventilation than perfusion, and then it lowers down into the vertebrae, so from dead space to shunt fraction. And obviously, prone position has the effect in traditional ARDS of making it flatter, so more homogeneous. And this has been replicated also in COVID-19. This is work from Sandra Rossi, and you can see these are patients in supine position of 5 centimeters of water of PEEP, and these are 35 centimeters of water of PEEP. You can see the great heterogeneity of ventilation gas tissue ratio, so much more in the sternal, much less in the vertebral. And you can see the effect of prone position in COVID-19 has been that of making it much more homogeneous, so very similar to normal ARDS. Now, this is a study comparing CT scan and EIT. You can see in blue the EIT is a ventilation map, and in red here is the perfusion map. So what you can see is two things. First, you can see recruitment in prone position, particularly of the dorsal regions, and a reduction, so a atelectasis in the ventral region. So we gain some, we lose some, but on balance, we increase recruitment. But what is more important, if you see these two maps, the blue and the red map, you can see there is a discrepancy in supine position. So there is more ventilation than perfusion, so in other words, dead space, and that has been normalized in prone position. Again, this is in COVID-19. The other things we can see is, again, there is more aeration, so gaining of extra sort of end expiratory lung volume over time in prone position, which has the interesting and important effect of reducing strain over time. So that's quite important. And clearly this has affected gas exchange. You can see here, for example, as the reduction, there is a reduction in non-aerated lung tissue, there is clearly an increase in PF ratio. So this is the same in COVID-19 as it was in a more typical ARDS, let's say. So you can see here a delta non-aerated tissue, so a reduction, and there is a reduction also in venous admixture. What about the outcomes? The outcomes will tell us this is a study where we compared normal ARDS, or typical ARDS, response between supine and prone, and COVID-19 between supine and prone. And you can see the pattern of response overall is very similar. So about 80% responders rate, commonly the same for typical ARDS and COVID ARDS. But what was important is that responders had a greater chance of surviving. And this has been replicated in other studies. And you can see here, I've simplified the study, but basically you can see there is no difference, at least statistically speaking, in the relative risk of death between ARDS and CARDS. But again, responders, strong signal towards improved outcome. And you can see the average treatment effect, about 52 millimeter of mercury per session of prone positioning. And what is also interesting here, you can see the PF ratio change between supine and prone, and then the greater the PF ratio increase, the shorter the duration of mechanical ventilation. So that's quite encouraging. What about timing? What we found from our study was that patients who were proned early, and by early I mean within the first 24 hours, did much better compared to the ones that were prone late. And this has a biological rationale. You can see this is a study from Sandra Rossi and Luciano Gattinoni's group. This is CT scans of patients taken first week, second week, and third week. And what you can see here, that during the first week, there is more atelectatic tissue. Atelectasis means essentially there's loss of gas, and when you change the pleural pressure, you might regain aeration. And you can see that this amount of atelectasis remains quite stable in the first 3 weeks. But the consolidation, so when the lung volume is preserved but is full of other things, so there is no air, but there is also difficulty in regaining aeration, that increases over time. And that has been associated with the recruitability or the improvement in aeration following prone positioning. But this is not universal finding. And in fact, in this study, for example, you can see that there is no much difference between early proning and non-early prone positioning. But then again, there are limitations in these studies because we don't know exactly when they met the criteria for proning. So it's possible that the first met the criteria for proning later on in their stay, rather than being a really late proner as a deficit in applying evidence-based medicine. And this is the same concept that comes from a different study from Northern Europe. What about duration? And duration is quite interesting because you can see here, and we all know during COVID-19, particularly the great load of patients. I mean, in my hospital, we had 61 prone patients to be prone each day. And you can see that some patients might have skipped 1 or 2 supine prone series, and some patients were prone for much longer. So you can say, what is the advantage of leaving these patients in prone position for longer? Let's say more than 24 hours. What about 48 hours? And this is some studies you can see here. The numbers are not huge, but impressive enough. 110 patients, you can see prolonged prone position, average 40 hours versus the normal average recommended about 17 hours. And yet there is a beneficial effect in terms of survival for patients who were more prolonged, received more prolonged proning. This is as a whole, but much more of an effect in patients with PF ratio less than 150 or 20 kilopascal, depending on how you prefer. The important thing is that there was a significant reduction in workload, as we might expect, but there was also very minor injuries, so there was well tolerated and quite safe. And you can see here that the gas exchange continued to improve beyond the first 16 hours. The other thing that we've done during COVID-19, and I think has changed what we've practiced over time, was awake prone positioning. And there were physiological effects of awake prone positioning. So you can see this is a study from Davide Chiumello. You can see not only did the PF ratio improve, but also the work of breathing. So the respiratory effort improved going from supine to prone position, which is very important as a patient relevant outcome. And this is a meta-analysis which I've redrawn just to simplify. You can see that there is no mortality benefit. However, there is a reduction in intubation, and that is seen particularly in patients who received advanced respiratory support and within the ICU. And when you look at this busy slide, but essentially I've highlighted the main point to say when you put all the studies together and you look at intubation as an outcome or mortality as an outcome, you can see there is no difference in mortality, but there is a quite good signal in favor of prevention of intubation. And you can see there, particularly if the PF ratio is below the 150 threshold. And this is my final slide before the conclusion, to say that there seems to be a dose effect or a duration effect. You can see here, for example, the risk of intubation and the risk of hospital mortality, which seems to be improving or increasing in terms of effect size with a longer duration. So you've got very little before 6 hours, and improves the size effect the more prolonged we can apply this intervention. And this brings me to, my conclusion. I hope I'm on time. Just to say that 4 points really. One, that responders to prone position have improved survival, and this is similar between COVID-19 ARDS and the typical ARDS. We've seen the response to prone position seems to depend and make sense physiologically on the dose, i.e. the duration of prone positioning. But then we need to be careful when we interpret changes in gases, so oxygenation importantly, but also carbon dioxide. We need to think about the vascular abnormalities that we see in COVID-19. So they might reflect both recruitment, but also might reflect the redistribution of blood flow. So we need to be mindful of the variation in the pathophysiology of the two conditions. And then clearly awake proning for at least 6 hours, if not more, are associated with a reduction in the risk of intubation. And with that, with 21 seconds to spare, I would like to thank you for your attention.